Hey, nice to meet you everyone. I'm Justin and I'm going to be talking you through the ENT revision lecture today. Hopefully this will be very helpful for you with your exam preparation as well as learning about the conditions. But before we get into that, just a quick word from our sponsor. So in terms of the contents of the revision lecture, we'll start off with some quick revision of the anatomy and basic concepts. Then we'll move on to ear pain and discharge, hearing loss, dizziness, vertigo, blocked nose, sore throat, and hoarseness. This should get us through the vast majority of the content so that we can give you the best shot on your exam. This is just a revision of the ENT parts of the matrix, so make sure that by the end of it, you're pretty well across all the R1s as well as the R2s to a certain extent. And we'll also cover some other topics that commonly come up on the exams. So just in terms of a bit of quick revision of anatomy as well as how to do an ENT exam. So in terms of some quick revision, the ENT exam covers a few things, including the ears, nose and throat, as you can probably imagine. So we're going to be discussing mainly the ear. So in terms of the external ear, you'll do your inspection and palpation. Particularly, you might want to also look for any localized redness or any signs of infection, or if there's any pain on, for example, when you're tugging on the tragus or the pinna, for example. You also want to assess the lymph nodes in the mastoid process, assessing for any signs of any inflammation or infection that could have spread. The internal ear, your gold standard, well not gold standard, but the most common examination you'll do will be otoscopy. This will be important for you to know how to do for your apexes, but also important to kind of have a good understanding of what findings you could expect in different pathologies, because that can definitely come up on your exam, as well as your OSCEs. So in terms of special tests, important to have an understanding of your whisper, Rene and Webers, which we'll talk about in a second, as well as your Dix-Hallpike maneuver, which I'm not going to expect you to do, but it's important to understand what it's diagnostic for. You also do an exam of the nose and throat, which you will have gone over in the past. On the bottom left here, you can see your basic ear anatomy, which will be some good revision if you're unaware of it. In terms of your definitions, the conductive hearing loss, that's your, if you look on the bottom left, your outer and your middle ear. And that shows signs on your Rene and Webers that we'll have a discussion about later, as well as on audiology. Sensorineural hearing loss also shows on Webers and audiology, and it involves your inner ear, vestibulocochlear nerve, and your brain, potentially. So on Rene, a normal finding will be your air conduction over your bone conduction, and conductive hearing loss will be bone over air. On your Webers, which will show you kind of whether it's where it localizes to, so which ear is affected, it'll be to the midline. If you have no pathology, it'll be to your sensorineural, it'll be to your normal ear, and for conductive, it'll be to your affected ear. So using those two tests together, it gives you kind of a decent understanding of if it's conductive or sensorineural, as well as which ear is localizing to. And there's a little bit of a cheat sheet on the right there. When you're looking at differentials for hearing loss, I find it really helpful to stratify them into conductive and sensorineural. Not only does this kind of group together similar ideas, but it also kind of gives you an idea of what potential causes could be and what areas they're affecting. Very good ones to know are your bread and butter otitis externa and otitis media. Also important to know about kind of earwax, cholesteatoma, and also your perforation as well. Otosclerosis and eustachian tube dysfunction you have a little bit of understanding of, and an SCC is pretty rare, not really something I'd expect to see on your exam. Sensorineural, presbycusis, so age-related hearing loss, which is sensorineural. Noise-induced hearing loss, many ears, all very important to know and understand. Vestibular schwannoma is an R2 condition, so you should have a bit of an understanding about it. Labyrinthitis, good to know. We'll discuss about that later. And medications are a really important one to consider as well, particularly when you're treating an ear infection with antibiotics. It's important to understand potential risks there. And you can also have congenital and also something we call acute idiopathic sensorineural hearing loss, which we'll discuss a bit later, which is actually an ENT emergency and needs to be appropriately referred. Here's another just good little cheat sheet that I like to have a look at. It discusses for conductive hearing loss the condition, risk factors as part of your epi, and also your typical presentation. So, for example, otitis media with effusion, as you'll learn quite soon, most commonly is a complication of an upper respiratory infection. It can also be caused by barotrauma and allergic rhinitis. And the typical presentation will be unilateral hearing loss, gradual onset, a feeling of fullness in the ear, as you can imagine with the effusion, and no pain or only a mild discomfort because, as you come to understand, it's not really an infectious process so much. Now we'll have a discussion of ear pain. So there's a lot of differentials for ear pain, as you'll come to understand. However, the main ones we're going to be talking about will be your otitis externa and otitis media, and we'll also do a bit of an explanation of the others as well. It's important to not only consider ear, kind of what we normally consider to be ear pathologies, but also some other infectious causes. For example, Ramsay-Hunt syndrome, which is kind of shingles that affects the facial nerve. It can also affect the eye and also the ear as well. And other differentials like things like a foreign body, it needs to keep an eye on that. So that's why otoscopy is really important. Different kinds of referred pain, shingles, which we talked a little bit about earlier, as well as sinusitis as well. So it's important to understand that while ear pain can be caused by a direct problem with your ear, it can also be a referred pain or related to another infectious process. So it's important to keep a wide berth of your differentials that you're excluding. So discussing AOE, acute otitis externa. So it says, as is written, it's an inflammation or infection of the external auditory canal, as you can see on your top left there. Most commonly it's bacterial, so it's commonly caused by Staph aureus and your Pseudomonas, so like Pseudomonas aeruginosa. Most commonly occurs in people that are like, for example, swimmers, so it's called swimmer's ear, but also anyone who has like a lot of moisture in their ears a lot of the time. So this can be people, for example, who have earwax impaction. That can be a risk factor, as well as people, so for example, people that use a lot of cotton bud, they'll push the wax further into the ear. What will happen is the earwax will gather and contain moisture and put them at a higher risk of AOE. Also, people with skin problems, for example, say you've got dermatitis and psoriasis, then you've got a higher bacterial load, which can put you at a higher risk of infection. And diabetes, similar, but as you can imagine, localized immunosuppression as well. So in terms of your symptoms, you've got your red outer ear and ear canal, as you can see up there, and it's going to be quite itchy and quite painful. Particularly with TMJ, so temporomandibular joint movements, as well as what we call a tragus rub. So if you kind of pull or manipulate the tragus, that could be quite painful. They also feel a bit of what we call a fullness in the ear. So just feel like the ear's full, they can't get the moisture out. Sometimes you can also see discharge, or it's actually quite common in this condition to see discharge. Sometimes you can have hearing loss. Occasionally some fever and lymphadenopathy as well, particularly if it's becoming more of a systemic infection. In terms of the management, as with all conditions, you want to consider not only your pharmacological, but also your non-pharm. So make sure you keep your ear dry. Tell them you can't swim for 2 weeks until this is better, because swimming is the #1 risk factor for bringing it back and making it worse. And something they call the ear toilet, or the oral toilet, which is kind of a manually cleaning out the ear. Medical management, so something called Sofradex, which is a triple ear drop therapy. You've got your Dexa, so obviously a steroid, and then 2 antibiotics as well. Since it's quite painful, simple analgesia, so not opioids, but like your Panadol, Nurofen and that. If it's refractory to Sofradex, or if there's a perforation, then you can consider ciprofloxacin, which is quite good and non-ototoxic. If it's persistent and refractory to Cipro, Sofradex, and any other antibiotics you've given, you might want to consider maybe it's a fungal infection. In terms of longer term prevention, once they're better, you want to try and help them to avoid getting so much moisture in their ears. So things like earplugs in the shower, avoiding swimming, and also reducing your earwax in the ear as well. So obviously a bit of earwax in your ear is helpful, but you don't want to have tons of earwax and plugging up their ears. So acute otitis media is an inflammation of the middle ear. It's quite painful generally and is a complication of upper respiratory tract infection in most cases. So, while upper respiratory tract infections are generally viral, around 80% of otitis media is actually bacterial, most commonly from strep pneumoniae, Haemophilus influenzae, and a few other bacteria. It can also be viral, however, in some cases as well. In terms of epidemiology, infants are the most likely population to get otitis media. This is primarily due to the fact that their eustachian tubes are narrower, shorter, and more horizontal, as you can see in that picture there. This impacts the drainage and also makes it easier for an infection to travel from the pharyngeal area, so the oropharynx, up to through the eustachian tube and into the ear. Smoking exposure is also making it a higher risk, and also childcare. So being around more ERTs leads to a higher risk of this, as it's most commonly a complication of ERT. In terms of your symptoms, as mentioned earlier, pain in your ear, otalgia, is very much a symptom. There can also be fever and sometimes discharge. Vomiting can also be sometimes common, particularly in the case when there's an effusion present, as this build-up of fluid in the inner ear or the middle ear is causing upset in the feeling of balance or proprioception, which is leading them to kind of have that nausea and vomiting. In terms of infants, they're not really able to tell you how they're feeling. So if you're finding they're kind of crying all the time, they're not looking too happy, and they're repeatedly touching their ear, that can be a sign there might be a pathology happening, such as an otitis media. On otoscopy, commonly you'll see that the tympanic membrane will be erythematous and bulging. You might also find that it's having a loss of the light reflex, or more commonly just a reduced light reflex. In terms of management, so lifestyle management comes first. So just making sure that you're having your conservative management like fluids, analgesia, making sure you're resting. Try to prevent having water in your ear and avoid any exposure to smoking, because this is a risk factor. And once again, because it's quite painful, focus on simple analgesia. So no opioids, but Panadol, Nurofen, NSAIDs like that. In the case of acute otitis media, we don't really prescribe antibiotics routinely for children. The reason is because generally they get better without any complications. So what we'll do is we'll wait, review them in a few days, and then if they're still not feeling too well, or they're having an indication that I'll discuss in a second, then we'll treat with amoxicillin. So in terms of antibiotic indications, children that are less than 6 months of age or less than 2 years of age, if bilateral, if they have any complications like mastoiditis, which can be quite serious, leading to things like maybe an osteomyelitis or a meningitis perhaps, any perforation, which can lead to longer term issues. If they're having quite severe pain or a fever for over 48 hours, particularly a high fever, if they're toxic or systemically unwell, or if they're Aboriginal or Torres Strait Islander origin, because they have an increased chance of chronic infection as well as complication. Children with cochlear implants are also at risk, because you don't want to have any further insult to the ear, which could lead to further hearing loss. So as previously mentioned, AOM has quite a few complications. We'll be having quite an extensive look into chronic otitis media with effusion, as well as chronic suppurative otitis media. And we'll also have a look into perforation of the tympanic membrane as well. So mastoiditis, as I mentioned before, can be quite severe. It's an ENT emergency, and you need to do an urgent referral, because it can lead to things like osteomyelitis, can spread to the brain, meningitis, and it can also form an abscess that can be quite severe. Bacterial labyrinthitis, so as we'll discuss later, it can be a cause of dizziness, vertigo, and hearing loss. Odontogenic abscess, that's not something you want, it's an abscess. And can also even lead to a CVS thrombosis as well. So regarding kind of distinguishing acute otitis media, acute otitis externa, and other different kind of pathologies, there's a few things that I like to think about. So I like to think about the age. So otitis media and otitis externa, they are both much more common in children. If it's an adult, you might be considering, like, obviously think about it, but other pathologies start to become a bit more likely. If the pinna causes pain, so like that tragus rub causes pain, then otitis externa is it's very, very likely. But you also need to exclude other secondary pathologies or other pathologies as well. If the tympanic membrane is visible, then probably not cerumen impacted. Then you want to assess it, see if it's bulging or is it erythematous, so be a sign of acute otitis media. Light reflex, if it's present, if it's not present, if it's not present, that's another sign of otitis media. And if it's perforated as well, that's important to know. In terms of discharge, if there is any, if it's mucopurulent, then that's kind of a sign of a more middle ear pathology, so maybe acute otitis media. Whereas more of a cheesy discharge, that's much more common in your acute otitis externa, so your AOE. And if there's any lymphadenopathy, that can be a sign that it's either spread, the infection or inflammation has spread, or potentially it is from another pathology to be considered. So the next topic will be about ear discharge. So there's a few different differentials of ear discharge that we're going to be covering. So in otitis media, there's two different kind of chronic otitis mediae that we can discuss. So chronic otitis media with effusion, COME, and chronic suppurative otitis media, so CSOM. So when you're looking at your COME, it's when you're having that effusion in the otitis, so like that chronic effusion, without any other signs of infection or inflammation. It's called glue ear. That's a kind of layman's term for it. And normally it lasts around 3 to 4 months. However, it can last longer and need management. So in terms of your risk factors, so recurrent otitis media is a big risk factor for it, and it's most commonly observed in toddlers. Also, if you're someone who has eustachian tube dysfunction, so basically you're struggling to kind of drain the fluid out of the ear, then you can have that kind of fluid build up, which can put you at a higher risk of that effusion. So your clinical features, you have that painless pressure sensation, so that fullness in the ear, and you also have a conductive hearing loss. This can be quite bad, particularly when you're thinking about the population that it's most commonly in. So there's toddlers, they're just learning to speak and they're learning to listen and speak. So if they can't hear you, particularly if they got bilateral COME, then that's going to really affect their speech and language development. So it's important to diagnose this, and it's actually a common cause of language and speech delay. And when you're on doing your otoscopy, you'll see that fluid behind the tympanic membrane with or without bubbles. So with your management, you want to do audiology and tympanometry at baseline. The reason for that is because you want to know what they're like at the moment so that you can kind of understand are they going to get worse, are they going to get better, what's happening there. And you want to follow that up. You also want to refer them to ENT for management because, as we mentioned, it can cause long-term effects. If they're of Aboriginal or Torres Strait Islander origin, if they're having developmental delay, if they have Down syndrome or structural abnormality, these people are at a higher risk of complications, then you can consider antibiotics. Indications of grommets. So if they have persistent glue ear for over 10 weeks, and also if they have bilateral conductive hearing loss, then that's an indication for grommets. So you'd want to do an earlier referral to the ENT for consideration of that. If they're having recurrent otitis media or recurrent bacterial infections, so it's affecting them quite a lot, then grommets can help them to stop having that kind of chronic insult and chronic complication. And if the effusion has lasted for a prolonged period, greater than 6 months, and just won't go away, then grommets are also indicated. So with CSOM, that's when you're having otitis media, but it's actually had a perforation of the tympanic membrane. So you're getting suppurative exudate. Same epi as COME. And the clinical features will be your painless discharge and a conductive hearing loss. The management that is the same for both is that you'll do audiology and tympanometry at baseline and then follow it up. And you'll also need to do an ENT referral because it can cause that hearing loss. In terms of the specific management for CSOM, you want to clean with microsuction and mopping, so make sure you're cleaning it out as much as possible and cleaning it out an appropriate amount so that it's not kind of getting gunky and creating a risk of infection. And ciprofloxacin eardrops. So because you've got a perforation of the tympanic membrane, you can't use any ototoxic antibiotic, so use ciprofloxacin, which has a low amount of ototoxicity, for 3 days. Until it's free of discharge for 3 days. So you're just making sure you're treating it. So cholesteatoma. This is, as you can see on the picture there, you've got that accumulation of your keratinizing squamous epithelium. So you can kind of see how it looks kind of like, you can see the keratinocytes there. And essentially what's happening is you're getting the ear canal skin inside the inner ear, so in the middle ear. This can cause problems. So it can erode further into the middle ear and it can destroy these structures like the ossicles and even can spread to the mastoid bone. These can cause permanent hearing loss. We're not entirely sure what causes it. However, it needs surgical intervention. So you need to do an immediate referral to stop things like hearing loss, as well as what we call an attic perforation. So a perforation kind of the tympanic membrane up that top area, which is suspicious and difficult to treat. In terms of risk factors, so tympanic membrane perforation and inflammation, as we know, there's no cause, but you can imagine having that inflammation growth there can lead to some issues. And chronic otitis media is also a risk factor. In terms of your symptoms, so conductive hearing loss, as well as kind of recurrent ear infections, because you're kind of having that, if you're having a perforation, for example, that can lead to chronic infections, as well as this foul smelling discharge. So kind of when you think of cholesteatoma for your kind of cluster questions or spot diagnosis, a conductive hearing loss and a foul smelling discharge from the ear with recurrent ear infections would be what I would consider to be a good buzzword. You can also have ear pain sometimes, as well as a feeling of fullness in the ear. So as mentioned earlier, urgent ENT referral, because you need to cut it out, is the only treatment that will work. And as mentioned, complications can lead to permanent hearing loss through destruction of the ossicles and can even erode to the area of the mastoid bone. And if you're thinking about anatomically what's surrounding that area, so the facial nerve, and you can even do damage to the labyrinths, which can cause permanent pathology. So now I have a bit of a look at hearing loss. So on audiology, which we discussed briefly earlier, it can be quite easy to tell the difference between conductive and sensorineural hearing loss. So when you're looking at conductive hearing loss, you'll see that clear separation between your air and bone conduction. And you can tell from what I've said that that's a conductive hearing loss. The most common cause of this conductive hearing loss will be otitis media, particularly in children. Sensorineural hearing loss, you're not having that conduction difference between bone and air, and you'll often see a dip towards the higher frequencies. The most common cause of hearing loss is sensorineural hearing loss, particularly because it happens in pretty much everyone who grows older, so presbycusis. So as we age, it's quite likely to happen. And also noise-induced hearing loss is a big problem, particularly in occupational medicine. In terms of some tricks to tell the difference between conductive and sensorineural, If they're having that gap between air and bone that I mentioned, that'll be conductive. If they're having that slope together, that's sensorineural. The backwards Nike tick that you can see there, or Nike, sorry, is pathognomonic of, well, not pathognomonic, but that's what you see in presbycusis. So they have that kind of dip and then ticks up a bit. When you're having a dip at a specific frequency and then it comes back up, that's showing as a sign of noise-induced hearing loss. Because around that 4,000 hertz band, that's kind of where you'd expect to see the noise-induced hearing loss, because that's the frequency that those most commonly offensive noises will be at. And then it's just at that area that it comes back up to baseline or close to baseline after that. That's showing that it's not that kind of age-related insult that is seen in presbycusis where it's kind of all affected. It's just that one specific area and then it comes back up after. So even though there's a dip in both, the presbycusis, you just have a little bit of a tick at the bottom, whereas noise-induced hearing loss, you expect to see a greater recovery. So, conductive hearing loss. Otosclerosis is an abnormal bony growth on the labyrinth, and it causes a progressive hearing loss. So if you look on the bottom right, you'll see having the stapes, which is having an overgrowth of the bone into the labyrinth area. So your middle ear bone is expanding to the labyrinth, and this causes this bilateral conductive hearing loss that is gradually progressive as the bone continues to overgrow and invade. It also leads to a tinnitus, which can be quite distressing. It's commonly affecting 20 to 30-year-olds, females more than males, and hormonal changes are associated with it. Treatment, as you can kind of imagine based on the picture, is ENT referral for a stapedotomy, and they'll replace the diseased bone with a prosthesis to help conduct the sound. So in terms of cerumen or earwax impaction, the treatment is cerumenalytics or eardrops, Docosette sodium, or olive oil as well. And what they do is they essentially help to break down the earwax and let it kind of come out of the ear by itself. If this doesn't work after a few days to a week, then they'll use ear syringing or irrigation, which can get rid of the earwax. But they'll still get you to put the cerumenalytics on to make it a bit softer so it's easier to syringe. There is a bit of a risk of trauma or perforation when you're doing ear syringing, however it's generally quite safe. Also, you want to make sure you're avoiding Q-tips because that'll push the earwax in even further and make it more of an issue. So perforation of the tympanic membrane, lots of things can cause this. So infections, barotrauma, so like pressure on scuba diving, a loud noise like a gunshot going off next to you. Also cotton swabs as well, or Q-tips, so they can actually puncture the membrane. So that's why it's recommended, one of the many reasons it's not recommended to use them. Symptoms, they can include ear pain, hearing loss. You can have tinnitus, which is relatively common, and also you can have discharge from the ear. When regarding the tympanic membrane perforation, when you're looking at it on otoscopy, there's a couple of things to understand. If it's in the lower half of the eardrum, it's generally considered to be safe, and it usually will resolve by itself, so there's no treatment required. If you're seeing an attic perforation as shown earlier with the cholesteatoma, or it's having that foul-smelling purulent discharge, which is another tiny cholesteatoma, then it will need an ENT referral for a surgical removal. So eustachian tube dysfunction. So this is essentially this plugged ear sensation that people get, or a clicking, and it's caused by negative pressure in the middle ear. In terms of risk factors, so inflammation or edema. So having like an urti or an allergy can contribute to this. Barotrauma as well. So things like flying in a plane, they can cause quite a bit of pain if you have eustachian tube dysfunction. Even when you're driving or changing elevation, so say you're going up a hill or down a hill, a very steep hill, then you can also have kind of this eustachian tube dysfunction affecting you. One of the pages I saw on GP actually did. So it's also more common in women, and it's improved when you're swallowing because that helps to equalize the pressure. So Your general presentation will be an older woman who has kind of this fullness in the ears and reduced hearing, and she also hears audible clicks when she's swallowing. It's worse during changes in altitude and can be painful. It's quite difficult to treat actually, so for a third of people, fortunately it will spontaneously resolve, and but in another group, the larger group, it's recurrent and there's no really any benefit for any steroids, unfortunately. In terms of other treatments, you can consider grommets as your last line if nothing else works, but there's also things like autoinflation devices which can hopefully be helpful. Sensorineural hearing loss. So presbycusis is the most common one. So this is age-related, and most commonly they'll have difficulty with the high-frequency sounds first. So oftentimes you'll have like an older gentleman, and they'll say, "I'm having trouble hearing my wife when she speaks." It's worse when there's background noises, if there's music in the background, for example, or the TV, and it's progressive and bilateral. So it gets worse over time as in both ears. The treatment is minimizing loud noise exposure. You don't want to have a secondary noise-induced hearing loss there. And also you want to maximize the hearing. So having hearing aids and cochlear implant, that's helpful in that it helps them hear better, but also it lowers the risk of things like dementia by increasing the brain stimulation. Noise-induced hearing loss. So it's at a particular frequency, and basically, as I mentioned, it's normally around that 4,000 hertz that it'll happen, and you'll have basically it'll come into your ear and it'll be really loud and it'll damage the hair cells in the cochlea. So risk factors, as I'm sure you can easily imagine, is just exposure to loud noises. So very bad in occupational areas, very bad in clubbing, kind of like when you're out in the clubs. So symptoms, hearing loss, tinnitus is also a big one, and hyperacusis. So actually you become more sensitive to noise and it can be quite debilitating and distressing. Sudden sensorineural hearing loss. So normally unilateral and also rapid onset. So someone will just suddenly have a hearing loss in their ear and also potentially tinnitus as well. It's an ENT emergency and you need to refer like ASAP to an ENT because the causes can be something like stroke or an autoimmune illness, and you need to start on really high dose of pred, like way higher than you've probably seen used on the and that's because it can lead to permanent deafness. So vestibular schwannoma, acoustic neuroma, well, it's the same word but different. So that's basically a benign tumor of the vestibulocochlear nerve in the cerebellopontine angle. If it's bilateral, it can be related to something you might know from peds, which is syndrome neurofibromatosis type 2. You can also have symptoms like unilateral hearing loss and tinnitus. So most commonly unilateral, but obviously in so that syndrome, then it'll be bilateral, but most commonly it's unilateral. You can have also changes to your balance as well, and sometimes even cranial nerve palsy if it's impinging on certain cranial nerves or invading into them. So the treatment, in terms of your treatment, so your investigation will be an MRI scan, as well as audiology, or an audiogram, ENT referral, and then they can decide basically how it's treated, but surgical excision is your gold standard treatment. We'll discuss a bit later also about Meniere's and labyrinthitis. So just discussing dizziness for a bit. It's important to understand that dizziness is not actually a diagnosis, but rather a symptom. While we're talking, we're going to be focusing on vertigo, but there's 4 main causes. So as well as vertigo, which is around half, there's also presyncope and syncope, disequilibrium, lightheadedness, and psychogenic causes. There's also 10% of causes that are considered to be other. So postural hypotension, that's probably another big one to think about. Anemia as well, hypoglycemia, and stroke. So these are pathologies that you should rule out as well. So in terms of dizziness, There's a few different categories, as I mentioned, and the pathophys of each one is kind of there, and the different kinds of illnesses or conditions that are related are there as well. So that's a good little cheat sheet to think about when you're trying to think of the differentials. So in terms of your causes of vertigo, you've got your peripheral and central. There's a few differences between peripheral and central that's important to understand. So in terms of your nystagmus, when you're having a peripheral pathology, so that's damage to the vestibular apparatus or the vestibular cochlear cranial nerve, your nystagmus will be horizontal or it can be torsional or rotatory, but it will never be vertical. That's very important to understand. And also, say you've got BPPV and you're doing a Dix-Hallpike, there'll be a delay between your Dix-Hallpike and your nystagmus being produced. And your nystagmus will last for less than 1 minute. In terms of your central pathology, so that's vestibular structure in your brainstem or cerebellum, you can actually have a vertical nystagmus. So if you see a vertical nystagmus, it's always central. Not even until proven otherwise. It's just never peripheral. Or okay, you can't say never, but 99% of the time. Horizontal, it can also be torsional rotator. So those ones obviously wouldn't be excluding peripheral, but vertical is a big red flag. There'll be no lag between your Dix-Hallpike and your nystagmus, so it's not affected by that peripheral kind of movement, and it can be a longer lasting nystagmus. So your differentials, BPPV, so worse with movement and certain positions, vestibular neuronitis and labyrinthitis, so that's vertigo or vertigo and hearing loss, and that's associated as a complication of an upper respiratory tract infection. Meniere's disease, so your triad of tinnitus, hearing loss, and vertigo, there's episodic and acute episodes. Acoustic neuroma, which we discussed earlier, as well as trauma as well. Your central pathology is most commonly due to kind of, when you think of a central pathology, you think of kind of tumours and strokes first, right? So anterior, inferior cerebral artery, posterior, inferior cerebral artery stroke, so your kind of your posterior circulation will lead to your kind of stroke symptoms as well as this vertigo. It can also cause things like kind of disequilibrium, cerebellar signs, for example. Vertiginous migraine, so it's a migraine that also has symptoms of vertigo along with it, as well as the other migraine signs like aura and nausea, vomiting. Space occupying lesion, for example, a tumor in your brainstem. Multiple sclerosis as well, good to think about. It's not common, but I mean, if it's something to exclude. Vertebrobasilar insufficiency, also less common, but important to exclude. In terms of your symptoms, so your peripheral signs, more likely to have auditory features. They're more likely to be sudden onset, severe and self-limiting. So especially something like Meniere's and vestibular neuronitis and labyrinthitis, they'll come on quickly, they'll be severe, and they'll kind of go away, at least between episodes in the case of Meniere's. Nausea and vomiting, and also a quick compensation as well. So in terms of your central though, there's less likely to have auditory features. You've got your 4 Ds of diplopia, dysphagia, dysarthria, dysmetria. As you can kind of imagine with more of a cerebellar pathology. And you've got a slower compensation. So this is a slide just discussing the HINTS assessment. So as previously I'm sure you may be aware, the HINTS assessment is comprised of 3 components: the head impulse test, nystagmus, and test of skew. The goal of the HINTS assessment is to distinguish between whether vertigo is coming from a peripheral cause or if it's from a central cause. And this is to be used in patients who are having this persistent vertigo as opposed to episodic, and it should be done during an episode of vertigo. As it can be seen here, it's quite sensitive and specific for acute stroke or a central cause in acute vestibular syndrome. And it's very helpful to use and understand. I've also included a video there. This video is probably the best that I've seen on the HINTS assessment and includes patient examples as well. So I definitely recommend giving it a watch when you have the time. And it's just a good cheat sheet to have a look at and think about. Kind of stratifying the different kinds of causes of vertigo, along with their time course, history. So, for example, vestibular neuronitis is most commonly post-ERTI, and your findings on examination. So, when you're doing your HINTS assessment, what will you see, and what would you expect to see? So, your benign paroxysmal positional vertigo, so BPPV, doesn't last very long, 30-40 seconds, and it's provoked by kind of your changement of head position and movement. Most commonly something like rolling over in bed. It's considered to be due to these kind of crystals that are in your semicircular canals. And they can be idiopathic, but they can also be caused by kind of trauma or infection. So, diagnosis and treatment. It's important to understand the difference between your Dix-Hallpike and your Epley maneuver. So your Dix-Hallpike maneuver, that's a diagnostic tool, and it will show you a lateral nystagmus towards the side of the lesion. And it will basically induce BPPV. So they'll be quite unwell when you do this. Then your treatment is your Epley maneuver. So it's a specific maneuver that can kind of hopefully stop those free-floating particles from free-floating, causing problems. You can also use treatments like prochlorperazine and promethazine, which are quite helpful. So, for example, Stemetil is very helpful, but they do have a risk of side effects, and particularly as they can act on the dopamine receptor, they have a risk of extrapyramidal side effects and acute dystonias like oculogyric crisis. Vertiginous migraine, so this one lasts a bit longer. It's basically a migraine, but it also is associated with vertigo symptoms and disequilibrium, but not always disequilibrium. So you'll have your photophobia, phonophobia, and sometimes aura, like most episodes of migraine. And it has to be during at least 2 episodes of vertigo. So they have to be connected, if that makes sense. In terms of your management, so like all migraines, avoiding your triggers, managing your acute attack with like simple analgesia and triptans, and also prophylaxis, so longer term propranolol and amitriptyline. Vestibular neuronitis. So this one can last for quite a while. It's most commonly post-viral, and it's due to inflammation of your vestibular nerve. It's self-limiting and normally only happens once, so you'll get it and it'll be around for a while. It'll be really, really bad, but it will normally not recur. When you're having hearing loss as well as vestibular neuronitis, that's considered labyrinthitis because it's basically spreading into the labyrinth. It's most common in younger people and up to around middle age, but it can happen at any age, of course. So it's basically a sudden onset, very severe vertigo that doesn't change based on your position, as well as nausea and vomiting. This can be very disabling, very distressing, and it's important that it's treated, assessed appropriately. They often won't have it tinnitus or deafness, and your head impulse test when you're doing your HINTS assessment will be positive. So, in terms of your treatment, reassurance that, as I mentioned, it's self-limiting and it normally only happens once. And they might be like, that's not helpful. I'm in so much pain. It's so terrible. And then you can say, well, there's some medicines we can give, like Stemetil, but you can only have them for 72 hours in your acute phase to kind of tide you over. And that's because after that 72 hours, it can actually delay recovery. Explain to them, reassure them, it normally resolves spontaneously. But if it's longer term, then we can do a referral for vestibular rehab. So, if you're having both hearing loss and vertigo, there's a few things it can be. Meniere's disease is really important to understand. You've got an excess of endolymph in the inner ear, and that can cause problems like vertigo, hearing loss, and a really, really debilitating tinnitus. It's also episodic. So people with Meniere's will often call it something like an attack that will come on out of nowhere. They'll suddenly just have terrible vertigo, sometimes nausea and vomiting, basically always nausea and vomiting because they're having terrible vertigo. They'll have a hearing loss that will come on acutely, and it'll normally be a low frequency sensorineural hearing loss, and a debilitating tinnitus that will come out of nowhere. and these attacks can be quite distressing and debilitating. So in terms of your treatment, there's some lifestyle changes you can make. So you have a lower salt diet, because as you imagine, it's due to large amount of fluids, and also decreasing your caffeine and alcohol. In terms of appropriate referral, you want to refer them to an ENT for management, want to refer them for vestibular rehab, and occupational therapy can be helpful too. During the acute attack, you can give your prochlorperazine, maximum of 3 days though, because as mentioned, it can cause those central habituation things, and that can actually not be helpful with recovery and makes it less effective. In terms of your drugs, in the kind of the longer term as well, you can use diuretics, beta histidine, and yeah, those are pretty good. Labyrinthitis. So labyrinthitis is important to understand. It's an infection or inflammation of the labyrinth system. As we mentioned before, when you're having vestibular neuronitis, that's inflammation of the vestibular nerve. But when you're having that hearing loss added onto it, it's basically saying that it's spreading into the labyrinth system. So you've got that vertigo from vestibular neuronitis and also a hearing loss. It's acute onset, persists for a few days up to a few weeks, and commonly is post-viral, post an ERTI. You'll commonly see a positive Romberg test. So that's basically saying, so Romberg's test is a test of proprioception. And essentially what it's saying is that the proprioception is affected, and that's causing these kind of vertigo and hearing loss issues. Because as you can imagine, the inner ear has a lot to do with your balance and proprioception. And your treatment will be with Stemetil as well as prednisolone to decrease the inflammation. So when you're suspecting vertigo, or also when you're doing hearing loss history, it's important to stratify your different kinds of vertigo. So in your history taking, you want to know, is it episodic or continuous, and how long does it last? Is there an associated hearing loss and tinnitus? Is it provoked by movement, or is it unrelated to movement? Are there any kind of additional symptoms? Is there a headache or a migraine? Is it preceded by an illness, specifically an ERTI? And is it worse when you're coughing, straining, Valsalva? So just summarizing hearing loss and vertigo, it's helpful to kind of use these tables to stratify, for example, the episodic versus persistent vertigo and whether it causes hearing loss or not, or rather hearing loss is associated with it or not. So for example, you've got episodic vertigo with hearing loss, you've been thinking Meniere's. If you've got persistent vertigo, if it has hearing loss or doesn't, then you might be using that to distinguish between vestibular neuritis and labyrinthitis, along with your other diagnostic evaluation. This also just kind of helping to summarize it all in one table, and whether it's episodic, once off, and how long it takes to kind of begin and remain. So just a brief discussion on blocked nose. So there's a lot of different differentials for nasal congestion. These can range from things like the common cold to hay fever, something called retinitis medicamentosa, which we'll discuss soon, even to something rarer like nasal tumors. So rhinitis. So basically that's an irritation of your nasal mucous membranes. The most common cause is the common cold, acute viral rhinitis. So you get the symptoms of your blocked nose, runny nose, and also a postnasal drip. Runs for around like 7 to 10 days generally, and as we know, children get a lot of them, 7 to 10 a year. Allergic rhinitis or hay fever can be acute, chronic, acute on chronic, and it's just the inflammation caused by inhaled allergen. So it's Ig mediated type 1 hypersensitivity, and it's most commonly seasonal. So you get like those grass pollens that can come out seasonally and cause hay fever. When you're thinking of hay fever, always screen for your atopic triad. So if you've got hay fever, make sure you're checking for asthma and eczema as well. Your symptoms, as we know, so you might have blocked nose, runny nose, and sneezing. When you're thinking of hay fever, you want to be reducing your allergen load. You can use an antihistamine, oral or intranasal, both good. You can have an intranasal steroid like Nasonex, and in some cases also a leukotriene antagonist like Montelukast, which can interfere with that allergy pathway. Complications can include nasal polyps, which can be not great because they can contribute to things like rhinosinusitis chronically. So rhinosinusitis, that's your inflammation of not just the nasal mucosa, but also your nasal sinuses. It's typically viral, but in some cases you can get a bacterial infection too. And also in quite rare cases, it can be fungal as well. You have to have either discolored nasal drainage, which can be either anterior or postnasal, or a nasal obstruction, so essentially a blocked nose, or both, of course. Also, quite commonly, you have the frontal facial pain, and that's worse when you're bending forward, because as you can imagine, the blockage and the fluid is moving around, irritating the area. And also commonly a headache. Reduced smell, so reduced smell sensation is also not uncommon, and in some cases you can get anosmia. So when you can consider if it's bacterial rather than viral, some red flags for you would be if the symptoms are quite severe and persistent, particularly if it's a higher fever as well, so 39, 40 plus for a few days. There's also this buzzword idea of the double sickening. So you're getting an improvement and then you're getting a worsening in your symptoms later on, a couple of days later. So since it's mostly viral, conservative management is the first line in most cases. So that's your hydration, simple analgesia, and also saline douching. Nasal decongestants, in the short term, they're fine to use, but in the longer term, they can cause this thing called retinitis medicamentosa. So essentially what's happening there is over time, when you're using nasal decongestants, you actually get a rebound dilation of the veins or the arteries, and they're causing this congestion from inappropriate use, which is going to just make the symptoms worse and worse. And you just need to tell them to stop taking them, and it'll get better over time. Indication for antibiotics. So if they're having symptoms for over 7 days with this purulent discharge, so pus filled, if they're having tenderness of the sinus unilaterally, or if they're having a maxillary toothache, suggesting perhaps they might have an abscess. High fever for over 3 days, or worsening symptoms after improvement. So that's that double sickening I was mentioning. And treat it with amoxicillin or doxycycline. Some other things that we need to think about. Nasal fracture. So anytime you're thinking of a nasal fracture, you want to be able to assess the extent. So an X-ray is sufficient for the majority. If you need further information, you can consider a CT scan. So in terms of your treatment, if it's severe, you want to do an ENT referral relatively urgently within a week, and that's because it might need to be manipulated to prevent complications under anesthesia. In terms of your complications, you can get nosebleeds or laceration of the nasal mucosa, septal hematomas, or a cribriform fracture. These can be quite bad. For example, a septal hematoma can be quite an emergency because it can lead to an infection that can spread and cause meningitis, for example. And cribriform fracture can lead to rhinorrhea of the cerebrospinal fluid as well, which can also put you at the risk of meningitis. So epistaxis, also known as nosebleeds, is very important to get your head around. So most of them are what we call anterior nosebleeds. So most commonly it'll be a child picking their nose a lot. Maybe they'll have some trauma to the nose. It's also posterior. These are much less common. They can be caused by trauma, but also often due to something like anticoagulation, so patients on long-term anticoagulant therapy, blood disorders, or maybe they have hypertension, which is causing them to blow blood vessels, for example. In terms of pathophysiology, there's something we need to understand, which is this Little's area. So Little's area is an anastomosis of these different arteries around the nose. So they include your greater palatine artery, superior labial artery, your anterior and posterior ethmoidal, and your sphenopalatine arteries. This anastomosis here creates a ripe spot for nosebleeds and is most commonly will happen in this area. In terms of your management, people think of nosebleeds as relatively benign, but actually they can be quite severe. And so your first thing you'll do is actually your primary survey and resuscitation if required. If you've got an anterior epistaxis, you can do head tilt forward, apply pressure on the nose, If that's not working, cauterization with silver nitrate can be good, nasal packing, or even a rapid rhino, which is similar to nasal packing. In terms of posterior, you get a Foley catheter or nasal packing, but this one has to be in the ED because it can be more severe. So nasal polyps, so mentioned earlier, they due to chronic inflammation, so things like hay fever, sinusitis that's left for too long can cause this. Most commonly bilateral. If they're unilateral, then that's actually neoplastic until proven otherwise. So you really need to investigate that pretty much ASAP and do an early referral to ENT. As mentioned, your risk factors are things that can cause chronic inflammation. Your symptoms would be postnasal drip, and also generally you'll have a blocked nose and a loss of your sense of smell. Diagnosis can be through visualization. Gold standard will be through endoscopy and cytology for eosinophilia as well, because you wanted to rule out cancer if it's unilateral. In terms of your management, you can use topical steroid drops for 6 weeks and see how it works. If it's refractory to medical management or it's not tolerated or any various reason, then early ENT referral for a polypectomy is indicated. Sore throat. So there's a lot of differentials for sore throat, but the main ones we're going to focus on will be your pharyngitis and tonsillitis. We'll also be discussing your glandular fever, scarlet fever, rheumatic fever, and a bit about Quinsy naphtous ulcer. And also, regarding your tonsillitis, we'll be discussing your Centaur criteria. So, in terms of pharyngitis and tonsillitis, pharyngitis is what we normally consider to be a sore throat. So it's inflammation of the pharynx, and since most are viral, around 90+%, it's a self-limiting condition. Symptoms, as we know, sore throat, sometimes a fever. In terms of treatment, you want to make sure just simple analgesia and antipyretics as required. Drink lots of fluids, stay hydrated, keep your oral intake up, particularly if you've got a sore throat. You can consider something like lignocaine or anesthetic lozenges. A lot is it to do with reassurance and explanation that 85% resolve by 1 week and serious complications are rare. Regarding antibiotic use, they won't be effective as a viral infection, and just explaining the risk-benefit analysis. So tonsillitis, that's, as we all know and love, an infection of the tonsils. Most are still viral, but a larger proportion of these are bacterial, mostly caused by strep pyogenes. The symptoms will be your sudden onset fever, sore throat, odynophagia, sometimes with cervical lymphadenopathy and tonsillar exudates. The criteria to consider antibiotic treatment is your Centaur criteria, so having temperature greater than 38 degrees Celsius and tonsillar exudate, having tender anterior cervical lymphadenopathy, and absence of Coffin's coryza, then you'd be considering it. You mainly use the Centaur criteria in between the ages of 3 and 14 years old, so you wouldn't use it any younger than 3, for example. And particularly, you'd want to consider antibiotic therapy in communities with a high incidence of rheumatic fever. An example of this is your Aboriginal and Torres Strait Islander origin. In terms of your common causes as well, could be EBV and CMV, as well as your bacterial causes. Treatment, so as most is viral, advice reassurance, keep hydrated, anesthetic lozenges as required, and analgesia. So as mentioned, you'll be considering your antibiotics if they are Aboriginal and Torres Strait Islander origin, if they have a history of rheumatic heart disease or scarlet fever, or if they're immunocompromised. Your treatment in general is your phenoxymethylpenicillin. You want to avoid amoxicillin because it can cause a maculopapular rash, which can be quite distressing. And if you're in a rural area or that you're considering maybe poor compliance, then IM benzathine benzopen can be really helpful because it only requires 1 dose. So in terms of tonsillitis complications, there's something known as quinsy. So it's a peritonsillar abscess. So basically the abscess is kind of forming and it can cause problems like it can cause deviation of the uvula, trismus, so a locking of the jaw, and also a unilateral sore throat. So kind of, when you're having that unilateral sore throat, trismus more on one side and the deviation, then you're kind of thinking, oh, what's this unilateral cause here? It could also cause dysphonia and difficulty swallowing saliva, as well as a fullness of the soft palate on the affected side. Fever is also common, particularly in the case of a spreading infection. In the case of quinsy, you'll admit the patient and get them to have the quinsy drained, so the abscess drained. They also put them on IV antibiotics and consider tonsillectomy because it can be quite severe and you don't want it to happen again. And as written, the etiology is most commonly your group A beta hemolytic strep, so strep pyogenes. In case of your indication for tonsillectomy, if you're having tonsillitis more than 5 times a year, that's an indication. Having quinsy, you should consider tonsillectomy. And also things like if you're having sleep apnea because your tonsils are too enlarged or your adenoids are too enlarged. Also, if you're thinking of cancer, probably worth doing it, but that's to be weighed up by the ENT. So 3 days after your tonsillectomy, you need to do some explanation to them about what they can expect. So pain can be quite severe, and you can also have referred ear pain, which we mentioned a bit earlier on. Adults can need 2 weeks or more off work because it can be quite severe and difficult recovery. However, and children, it's severe and they can take a while, but they're often quicker than adults. You also need to explain the risk of secondary bleeding, secondary hemorrhage, 5 to 10 days post-op, and that they should represent if there's any particular concerns. So glandular fever, also known as infectious mononucleosis, or the kissing disease. So most commonly in young people, spread by saliva, so sharing cups and utensils and kissing is quite common as a mechanism of infection. Epstein-Barr virus is one of the common causes. CMV is also a common cause. In terms of your symptoms, so you get your sore throat and enlarged tonsils with this whitewashed appearance, as well as an enlarged lymph nodes, fever, and sore throat. You can also get hepatosplenomegaly as well, which can be quite upsetting in some cases because you can get things like hepatic insult, and in some cases, due to the splenomegaly, you can get a ruptured spleen. So that's why you want to tell people to avoid contact sports for 3 months afterwards. In terms of your investigations, you can have a full blood examination and a heterophile antibody, also known as the monospot test. If that's inconclusive, consider an EBV serology. You can consider an LFT because due to the potential of hepatic insult. And also, if you're thinking it could be bacterial, you can consider throat swabs as well. So in terms of the management, so it's most commonly self-limiting. However, the symptoms can last for a few weeks. Make sure they're well hydrated and using simple analgesia, including things like lozenges and things to kind of, sometimes lignocaine can be helpful to stop the sore throat from causing reduced oral intake. If you're thinking it might be bacterial, then you can consider phenoxymethylpenicillin, as well as steroids for inflammation and swollen airways if required. In terms of complications, as mentioned, avoid any contact sports because splenomegaly can be an issue, and if you have a ruptured spleen, that's not good, it can cause mass hemorrhage. Hepatitis can also be a problem, so we suggest to avoid alcohol, and if you're showing any signs of symptoms or any red flags, to return for reassessment. Aphthous ulcer. So this is another thing we should think about. If you're having this persistent oral ulcer particularly, then you need to rule out tongue carcinoma. It's most common in people with a positive family history, so people who runs in families, and it gets less common with age. So the kind of symptoms are you have that white patch inside the lips around the gums, and it's most commonly on one side. And it also can lead to a sore throat as well. Your treatment is just conservative management generally, so hydration and simple analgesia. So scarlet fever. So an infection caused by your strep pyogenes, and most commonly in children 5 to 15 years old. There's quite a few symptoms that you can have. So you can have fever with your kind of red erythematous pharynx, as well as around the tonsils. You can have that kind of exudate. You can also get a rash, so it's often described as a fine sandpaper rash, and it commonly occurs in your groin, underarm, and elbow creases. And you can also have that strawberry tongue that's commonly mentioned as well. Another symptom that's not uncommon is the circumoral pallor, so the paleness around the mouth. Your management for scarlet fever or group A strep is phenoxymethylpenicillin. When you're talking about rheumatic fever as well, so that can be a complication of strep throat due to cross-reactivity. There's something called the Jones criteria. So you can need 2 major or 1 major and 2 minor criteria, at least, in a patient with a previous strep throat. These are the different types of criteria here. And one complication that can be quite bad is rheumatic heart disease, which I'm sure you've heard about. So another cause of sore throat is something called globus pharyngeus or cricopharyngeal spasm. So this is basically you get inflammation of your larynx, and that can be caused by just kind of habitual or due to anxiety or psychiatric illness. They're having this tightening or hypertonicity of the laryngeal muscles. So it kind of makes them, it's not really painful, but it feels like there's kind of a lump in the throat and a kind of a bit of a choking sensation. And the management is essentially psychotherapy, so cognitive behavioral therapy or relaxation techniques. In terms of hoarseness, so there's a lot of differentials of hoarseness. They go from quite benign, things like voice overuse and like viruses, to things like laryngeal carcinoma, which you need to be quite concerned about. Just quickly mentioning that if you're having a hoarseness that persists for over 4 weeks, that is laryngeal carcinoma until proven otherwise, and needs to be promptly assessed. So, laryngitis. Your symptoms of that hoarse voice, as well as a sore throat and upper respiratory tract infection. Most commonly viral, but it can also be due to just straining or any irritants of the larynx. So, for example, smoking. The treatments will be resting your voice. Humidification can be helpful, and analgesia if there's any sore throat. If it's due to an ERTI, then your other conservative management like hydration and keeping oral intake up is important. And yeah, if you're having it, as I said earlier, if it's present after 4 weeks, so greater than 4 weeks, then that's a red flag and needs urgent referral to ENT due to this risk of malignancy. So in terms of your red flags for head and neck cancer, if you're having any of the following lasting for more than 4 weeks, so your hoarseness, sore throat, having a stridor, for example, any difficulty swallowing, particularly an unexplained new onset difficulty swallowing, or a unilateral pain in the head or neck area. Those are big red flags. In terms of the signs that you will see, so not symptoms but signs, it's having a red or white patch on the mouth, a persistent oral, for example, an abscess ulcer, having a lateral, like a unilateral neck mass, unexplained swelling in the parotid or submandibular regions, rapidly growing masses, if they're having any signs of any mass effect like a cranial nerve palsy, orbital mass, or even if they have a unilateral ear effusion. And these are just some differentials for neck lumps. So it can go from things like a thyroglossal cyst all the way to something like a parotid mass to be assessed. You can also have a ciliary stone, like a submandibular stone, that can come and go, which is also something to consider. So in terms of other differences of hoarseness, there's Bell's palsy. I'm not going to belabor Bell's palsy because I'm sure you'll have a decent understanding, but it's a cranial 7 paralysis that's generally idiopathic post-viral infection. So you have an absence of the frown creases on the unilaterally due to the facial drop, which is non-forehead sparing because it's a lower motor neuron. that's affected. Also, you get a change in your taste, hyperacusis, and an inability to close your eye. So the cornea can be at risk here, and you can have things like an abrasion. So you need to tape over or protect the eye. In terms of your management, you need to rule out a stroke. Even though it's non-forehead sparing, you still need to rule out a stroke. You need to protect the eye and start them on a high dose of pred because it's due to that inflammation. You want to start it as soon as possible. Antivirals are a bit contentious, so I guess in the case they're a bit just screening for shingles here. Almost all patients, around 70%, will improve in around 4 to 6 weeks, and 29% will be left with some residual weakness, which may get better over a longer time period or remain. So Ramsay-Hunt syndrome. So that's a cause of this kind of Bell's palsy, but it's due to herpes zoster, so shingles. And basically what's happening is you're having that varicella zoster virus reactivating in your cranial nerve 7, so your geniculate ganglion of cranial nerve 7. And you can also have involvement of cranial nerves 8 and 9 as well. You'll have the vesicles on the skin, so commonly of shingles, and areas that are innervated by the facial nerve. So your symptoms will be dependent on which nerve is affected. So it's facial nerve, you have that ipsilateral facial nerve palsy, which is forehead sparing in this case, as well as potentially a spaced taste disturbance. If, for example, you're having your trigeminal nerve affected, then you can also have a Hutchinson sign, which is your red flag for herpes zoster oticus. The reason, so Hutchinson sign is that when you're having vesicles on the tip of the nose. And the reason that's bad is because the nasociliary nerve does the sensation for both the nose as well as the eye, which indicates that potentially you're having herpes zoster oticus as well. In terms of your management, so as with facial nerve palsy, you want to ensure you're having good enough eye cover as well as artificial tears if needed, because you might have your impaired eye closure. High dose, not high dose, IV acyclovir, particularly if you're concerned of herpes zoster oticus, and high dose steroids as well to control inflammation. Yes, and I've also realised that in Ramsay-Hunt syndrome, I've mentioned that it's forehead sparing. In actuality, as with your cranial nerve 7 palsy, it'll be non-forehead sparing because it's due to that lower motor neuron. And most people know it because Justin Bieber was infected. Justin Bieber suffered from Ramsay-Hunt syndrome in the past. Thanks, everyone. Hope this was helpful, and best of luck for your exams.